Hello, everyone, and welcome to the first webinar for a three-part series on Catalysts for Change. Today, we will be focusing on centering health equity and value-based care. This event is co-hosted by the Foundation for Healthcare Quality, Washington Health Alliance, and Comagine Health. My name is Emily Noodleman, and I am the Transformation and Community Partnership Manager at the Foundation for Healthcare Quality. In my role, I primarily support the BREE Collaborative program in the implementation of their reports into practice settings, and I also help support our health equity work. Before we jump in, I just would like to review some housekeeping items. First, you have all been placed on mute upon entering the webinar. You will have the opportunity to ask questions to our panelists today. Please write your questions in the Q&A box that is located at the bottom of your screen. We will not be calling on individuals to verbally pose their questions or comments to our speakers. But again, we will be reviewing that Q&A box. The webinar today will be recorded, and we plan to send out the slide deck and the recording to you via email, and we'll include the slides that have been approved by our speakers. The recording will also be posted on the BREE website. So why are we here? What brought us here today? The Commonwealth Fund states that value-based care ties the amount of healthcare providers earn for their services to the results they deliver for their patients, such as quality, equity, and cost of care. Through financial incentives and other methods, value-based care programs aim to hold providers more accountable for improving patient outcomes, while also giving them greater flexibility to deliver the right care at the right time. While value-based payment, according to the Washington State HCA, is a payment method for clinicians that rewards them for the quality of healthcare they provide rather than the volume or number of patients they see, the National Academy of Medicine describes quality healthcare as care that is safe, effective, patient-centered, timely, efficient, and equitable. Yet some research has found that some value-based payment initiatives have failed to advance that health equity piece, in large part because equity wasn't prioritized during their design and implementation. In the webinar today, we'll hear from representatives from different stakeholder groups within our healthcare ecosystem to discuss how they are promoting quality that centers equity in the forefront of their care and within the value-based care space, and how we can include equity more in that space. As a review for our agenda items today is we'll start with this introduction and overview. We'll then get to hear presentations from our speakers. After a presentation from our speakers, we will have a mini Q&A. So if you have a question specifically for that speaker, please place it there and we'll try our best to ask them a question at that moment. But we will also then take those questions that you are having for the speaker or for the general group and enter a large group discussion at the end of this presentation. And then we will work and wrap up the webinar today. So as we begin, we'd like to take a moment and bring Ginny Weir, Drew Oliveira, and Emily Transu forward to share work their organizations are doing to support health equity and in the VBP space. So I'll pass it to Ginny.
Thank you, Emily. And good afternoon, everybody. I always look forward to these really collaborative webinar series and thank our partners, the Washington Health Alliance and Comagine Health, for being with us today and for working towards these shared goals. I'm Ginny Weir. I'm the CEO of the Foundation for Healthcare Quality, and I'm really here just to welcome you and orient you to the work that we do within our healthcare ecosystem. So I come to work every day really because of our unique ability at the Foundation to bring together all of those who give, get, and pay for healthcare and seek to drive improvement. Our fragmented healthcare systems not necessarily oriented to helping all of us be healthy or really detect or manage disease. So we are home to a variety of programs all focused on convening and driving change. Our care outcomes assessment programs use clinical data abstracted from medical records into registries, really allow us to look at individual provider, site, and system performance. Our Washington Patient Safety Coalition is a collaborative of patient safety professionals dedicated to reducing harm and medical errors. Smooth Transitions is a quality improvement program focused on planned out-of-hospital births that then transition into inpatient care. And finally, the program that initiated this series, the Collaborative, is a public-private group of governor-appointed multidisciplinary stakeholders who select high-priority healthcare services every year around which to develop clinical guidelines that then work to implement those guidelines into practice. And Dr. Emily Transu with Comagine Health is newly our Collaborative chair, and we're really enthusiastic about her leadership here. And finally, in the spirit of collaborative equity action, I want to highlight our work over the past 3 years to develop a roadmap that was sponsored by our Washington Healthcare Forum and One Healthport to integrate health-related social needs screening, intervention, and tracking into clinical practice. So I'd encourage everyone to go to our website equity tab to see our guidelines, roadmap, and implementation resources. And with that, I will turn our screen over to Dr. Drew Oliveira.
If I can get off mute, I'll be good. But hey, thanks, Jenny. Like you, our work is really related to how do we help change the market and change the delivery of care for the better for most, if not all, Washingtonians. As you may know, the Washington Health Alliance is an organization of about 170 different organizations, from purchasers, plans, provider organizations, as well as pharmaceutical manufacturers and others. And we are an independent nonprofit, which is fun for us. And really our function is to do a couple of things. First is to collect data. So we have an all-payer claims database. We report on that every year. We just submitted our most recent report in January. Our reports have included, over the last couple of years now, an equity lens and really looking at where people live and how does that impact the quality of care, the access to care, the use of care, the costs of care. And that has opened a number of new questions for us. The second thing we do is we bring people together. So we have a collaborative that we are starting with some of our provider members to look at a roadmap to equity. Some of the same things that we're going to be talking about today. But whenever we bring people together, when we ever think about market changing things, we think of three things. First, the payment model has to be aligned to be able to drive those results that you want. A typical fee-for-service model is not going to do that. And so we look for alternative payment models within any of the activities that we're looking at. The second thing we have built into any of the work that we're doing is an equity lens. You cannot provide quality unless you're also addressing health disparities and equity in the system. And then the third thing that, based on our data that we've been focused on, is that everyone really deserves and should have a usual source of care. When people do not have that usual source of care, typically in a primary care practice, their results look worse. They don't get screened appropriately. The chronic diseases are not managed well. And when you look at their costs go up. $27 on the commercial plans, $57 on the Medicaid plans when you risk adjust those things. So those three components, equity, payment reform, and having a usual source of care, are what we build into any of the activities that we do. So we're really excited to listen to the conversation today because it's right up our alley. And with that, I'm going to pass it over to Emily.
Thanks so much. This is always such an exciting group to gather with, and it's always an honor to be part of this. I'm Emily Trancy. I'm the Chief Clinical Officer at Comagine Health. As people may know, Comagine is a bit of a many-headed hydra in terms of the different pieces of work that we do. We're mostly a services organization. We do a lot in care management. We work a lot in quality improvement and kind of at the elbow support for providers. We also have a research group and a substantial data group. So it's always interesting to sort of think of which of those to pick in terms of our equity work, because there's a lot going on in each of them. But today I wanted to sort of think a little bit about some of the work that we're doing around data specifically, particularly in Oregon and elsewhere. We've been working on the idea of a health data utility, which is essentially the idea. So many of us, and we see this here in Washington, we see it all over the place. There are lots and lots of different fabulous data efforts going on around claims data, around clinical data and CDRs, around health information exchanges that help data to flow back and forth, and community information exchanges where we're collecting community data. And yet all of these tend to be sort of siloed in different places. And I think health equity is a great example of why we need to bring all of that together and the power of bringing it together. As Emily and others noted earlier, the early work in quality often made equity actually a little worse because there was a tendency to do quality improvement with the patients it was easiest to do it with. And that's sort of the easiest way to bring up your kind of mean scores. But in doing that, you're often leaving behind the people who need it most. And to be able to track that and improve that and focus on the people who need it most, we really need to be able to bring together all those different sources of data, because you'll have key pieces in each one. And if you don't have the ability to connect them, then it's very hard to both measure what you're doing as well as to identify the points where interaction is going to be most impactful. So we've been really excited to be teaming with others in Oregon around how to bring those different data sources together and really turn that into something that ultimately everyone has appropriate access to, so it's not cordoned off with wonderful data hiding behind walls that nobody can get to. Obviously, appropriate security is critical to all of that, but really thinking of that as something that people in the healthcare system should be able to have appropriate access to, and should be able to braid and connect all those different sources of data to help make people's lives better, specifically in the equity space. So with that, I will hand back to Emily.
Thank you so much. Well, now we will get to our speakers. We are very excited to have our speakers join us. Depending on when you signed up, you may notice we had a little bit of changes. However, still the organizations have remained the same, and we are grateful for those who are able to join us today and to learn and listen from them. So first, we'll have Dr. Bindu Nayak, who is a doctor at Confluence Health in the Wenatchee area. We'll then learn from Linda Brady, who's the BVC portfolio manager at the Bowen Company. And we will have Dr. Angie Sparks join us from United Healthcare as well. So I will pass it off and invite Dr. Bindu Nayak to come forward.
Hello, everyone, and thank you for joining the webinar today. I am happy to share with you our health equity work that we've been doing at Confluence Health. I started working on health equity in 2017 when I started the Health Equity, Diversity, and Inclusion Council at Confluence Health. In 2018, my colleague, Dr. Mabel Bodell, and I have co-chaired the council since then and are now co-medical directors of health equity at Confluence Health. Next slide. So to give you some background on Confluence Health, it serves a 4-county area, and the demographics of our patient population are 73% of residents identifying as white, 32% identifying as having Hispanic Latino ethnicity, and the third largest group is 2.4% of residents identifying as American Indian. Next slide. So today I'm going to share with you 2 health equity projects that we have done. One is a health equity work that we've completed in the COVID-19 pandemic, and the second is an ongoing project that we're working on with pediatric asthma. Next. So in 2020, we had already been looking for health disparities in our community. So by the spring of 2020, the disparity in COVID-19 cases and hospitalizations became very clear very quickly. There were disproportionately higher cases of infection with COVID-19 and hospitalizations for COVID-19 for Hispanic individuals in our community. Next slide. Immediate action was needed to address this disparity, and an incredibly cohesive effort happened between community-based organizations, health centers, and public health to amplify vaccine outreach to the Latino community. In the beginning of the pandemic, more than 50% of COVID-19 hospitalizations at Central Washington Hospital were for Latino individuals. After this successful vaccine outreach, that number decreased to between 5 to 8% of COVID-19 hospitalizations were for Latino individuals by August of 2021. Confluence Health partnered with a community-based organization called Parque Padrinos. Their Madrinas de Salud coordinated outreach by doing pop-up vaccine clinics and vaccine outreach all over North Central Washington. The effect of this vaccine outreach is still apparent today in Chelan and Douglas counties. The rate of the percent of vaccination for the primary COVID-19 series for Hispanic individuals is slightly higher than it is for non-Hispanic individuals in Chelan and Douglas counties as of December of 2023. Next slide. And next slide. So we understand that community engagement is critical to health equity work. The vaccine outreach effort emphasized that maintaining these strong communication with our community-based organizations is critical. We also continue doing outreach by having an annual health fair, which we have in a local park that serves a predominantly Latino neighborhood in Wenatchee, where we offer informational health booths for all members of families. We also know that it's important to maintain readiness to address any emerging needs from our community and advocate for those needs. So we have been having health equity dashboards where we follow certain health metrics by race and ethnicity, and we do publish that internally to our employees, looking at different health metrics. One of the health metrics that we were following was pediatric asthma and emergency department visits. What we found in September of 2022 was there was a large spike in emergency department visits for children with asthma. Now, beginning in August of 2022, we had a severe wildfire season with weeks of very heavy wildfire smoke in our region. Next slide. So what we found was that there was a disproportionate increase in emergency department visits for children with asthma, and significantly disproportionate increase for Hispanic children with asthma compared to non-Hispanic children with asthma in our region. So this does appear to be an emerging community need, with pediatric asthma affected by climate change, wildfire smoke, which is creating a health disparity. Next slide. So around this time, my health equity team signed up for the BRE Health Equity Action Collaborative. Next slide. And we chose the BRE guideline of pediatric asthma to examine what factors were contributing to the disparity in emergency department visits for kids with asthma who are Hispanic in our region. Next slide. First, we looked at demographics of patients on our pediatric asthma registry by ethnicity. We found that 37.6% of kids with asthma are Hispanic on our registry, and 50.5% are not Hispanic. However, we found that the incidence of respiratory-related emergency department visits was 1.7 times higher for our Hispanic children with asthma compared to our non-Hispanic children with asthma. Next slide. We also asked the question, is there a difference in well child check completion by children on the asthma registry by ethnicity? And what we found was that in all age groups, a greater percentage of Hispanic children with asthma had completed their well child clinic visits compared to non-Hispanic children with asthma. Next slide. We also looked into the payer distribution for our pediatric patients on the asthma registry who had emergency department visits. And the majority of these patients had Medicaid as their payer. Next slide. We also reviewed research from the Washington State Department of Health looking at data on cardiopulmonary health effects from the last major wildfire that we had in the region in 2012. Next slide. During this wildfire season, Wenatchee had very high levels of fine particulate matter, or PM 2.5, for an extended period of time, with 34 days of bad air quality and 14 of those days having hazardous air conditions. Next slide. And during this wildfire period, the daily patient care visits doubled for children with asthma in comparison to baseline. Next slide. So to summarize our points of analysis, next, we asked the question, are the Hispanic children with asthma having their regular routine primary care visits? And the answer was yes. However, we found that there was a higher incidence of emergency department visits for Hispanic children with asthma. Next. We analyzed practice patterns in pediatrics clinic, and we found that asthma control visits were not regularly scheduled and asthma action plans are not used. Next. We reviewed the effect of the wildfire smoke data from the 2012 wildfire season, which confirmed a doubling of patient care visits for children with asthma in North Central Washington during that wildfire season. We presume that the doubling of emergency department visits for children with asthma during the 2022 wildfire season is also likely due to the wildfire exposure during that time. Next. We reviewed CDC survey study data from October of 2020, which reviewed households in Wenatchee and East Wenatchee and revealed a greater percentage of low-income households among Hispanic and Latino households in comparison to non-Hispanic households. And we reviewed research showing that children with asthma living in low-income homes are disproportionately affected by environmental factors that can trigger asthma exacerbation. Next. So our recommendations and plan after this analysis was first centering in the clinic setting. The pediatrics clinic is going to start having asthma control visits where they'll start to schedule preventive visits for asthma at least annually instead of only seeing the children with asthma when they're having problems. The pediatrics clinic will start providing an asthma action or management plan for all kids with asthma. The pediatrics clinic is going to provide a wildfire smoke action plan in addition to the asthma action plan for families with a child with asthma. Next slide. Or next. And from an equity perspective, we will continue analyzing our medical centers data and tracking the asthma disparities that are disproportionately affecting Hispanic children with asthma in the region. The pediatrics clinic is going to provide more culturally appropriate education on asthma to families in clinic, including information in Spanish for families whose preferred language is Spanish. Next. And collaboration. We will continue coordinating with community-based organizations, and the one that we will be working with is called CAFE, and we'll be working on educational outreach on asthma and wildfire smoke. We'll be continuing coordinating with the Chelan Douglas Health District. They have box fan filters, so we can distribute those to families with children with asthma. And we hope to advocate for better coverage by Medicaid for HEPA air filters for children with asthma, especially considering that children with asthma in Washington state from low-income households are more at risk from exposure to the fine particulate matter from wildfire smoke. Due to physiologic reasons, children are more at risk from that exposure. And we know that these wildfire seasons will probably continue to increase in frequency over the years. And next slide. This is the Wildfire Smoke Action Plan. It was created by Dr. Mary Crocker, pediatric pulmonologist at Seattle Children's, and it gives information on what to do before wildfire season starts, like making sure that all your asthma medications are at home and updating your asthma action plan, what to do during wildfire season, and it gives activity recommendations for what families should do depending on what the air quality index is at the time.
Thank you so much,
all.
Dr. Nyack. That was great. We had one question that came in that was just a clarification. Did you notice that were the asthma cases higher in the emergency room due to not having a PCP or advanced practitioner of any type, or was it just more from the smoke?
We think it's more from the smoke based on the fact that most of the kids with asthma were having their well child visits regularly. So we do think it is because of the smoke.
Yeah. And my follow-up question too is, I know when you and I were talking about this presentation, we were like, you're doing such great health equity work. And we're trying to think, how does that connect with the value-based payment and value-based care space? So as you're working on this health equity, how do you see this work could be further supported by a VBP or an alternative payment design?
Well, the one thing that I was thinking as far as, what's provided, most of our patients who were in the emergency department did have Medicaid as a payer. We know that medications are covered well, except for these air filters are generally not covered by Medicaid. And that's one of the key components to protecting children when they're at home. And if their air quality inside the house is equal to what the air quality is outside the house, there needs to be something to protect them from indoor air quality.
Great. Thank you for letting us know that. We will now transition to our next speaker. So I'll have Dr. I think maybe I mix this up 1 second. Yep, we'll have Dr. Angie Sparks come forward and talk about the work going on at United Healthcare.
Thanks so much, Emily. And I'll also give credit to Vicki Gruba, who produced these slides and is our national leader for this program and subject matter expert. Today I'm going to, so just to introduce myself, I'm Angie Sparks. I'm a family physician by training, and I am the Chief Medical Officer at United Healthcare, Washington Community and State, serving our Medicaid and dual eligible special needs members in Washington. Today I'm going to talk with you about a national program that we have been using mostly in other states, but are thinking about in Washington. And it's pretty new, but this is a way that we're using value-based payment to think about incentivizing care to address equity in the substance use disorder treatment space. Next slide. So before I jump into the program, I really wanted to share some context talking on some of the most recent national trends related to the opioid epidemic. And I know in Washington, we unfortunately are no stranger to this. We are seeing fentanyl flooding the supply chain, and in Washington, the introduction, unfortunately, of xylazine. And so we're in this fourth wave of the opioid epidemic, and that's really been dominated by polysubstance abuse. And this is really seen as the primary driver of the high overdose rate in the last few years. But from an equity lens, we continue to see in the literature disparities in the overdose death rate between racial groups, as well as disparities in who gets treatment and how long people are retained in treatment. So there's a graph on this slide, and you can see how very recently the overdose death rate for BIPOC individuals in the United States has surpassed that of white. And this is actually for the first time in recorded history, and the gap is widening. And so we also see disparities persisting in treatment rates despite frequent healthcare contact. So similar to the prior speaker, even though there's contact with the healthcare system, the disparity persists. In addition, between racial groups, we also see some disparities across geography, with rural counties in Washington and across the nation having much higher rates of low to no capacity to treat substance use disorder. A little over a year ago, we did have the elimination of the X waiver requirement by the federal government. So now our clinicians no longer have to have a special certification to prescribe buprenorphine. This is one of the primary medications that treats opioid use disorder. And it's also referred to as medication for opioid use disorder, or MOUD. And this really opens up access and gives us the opportunity to enable clinicians, particularly primary care clinicians, and those in medical settings, particularly to this program, hospitals and emergency rooms, to address disparities that I just described. This has largely been also driven by the fact that there are folks with injection drug use. The rate of new hepatitis C infections is more than 4 times than it was a decade ago in the United States. And we are seeing a greater focus on this endemic nature of opioid use disorder, HIV, and hepatitis C. But we're also seeing how an integrated public health approach and treatment approach could improve outcomes. Next slide. So with that background, there are really 3 primary drivers for us at Community and State and United Healthcare to prioritize delivering solutions that address opioid use disorder. Our goal is to improve the health of our members and help the healthcare system work best for everyone. Our first focus area is really quality. So there's considerable opportunity, of course, to improve outcomes and support clinicians in aligning with best practices around treatment for substance use disorder. And we need to add, in order to do that and improve the quality, we need to address many barriers to access and treatment. Our second driver is our state partnerships. Medicaid is a state-by-state program, and Washington is no different. So it is our job to align with our state's public health priorities, the healthcare authority, and the Healthcare Authority and others expect us to impact clinical outcomes and offer solutions in the opioid use disorder and substance use disorder space. And that's across the country as we're experiencing this fourth wave, as well as to improve the integration between medical and behavioral health care. And the third is that our opioid use disorder strategy aligns with our population health and equity framework, which is shown here. Within the deployment of this framework, prioritizing opioid use disorder more broadly and inclusive of disparities in treatment rates as a theme in the states we serve. Next slide. So in addition to the opioid use disorder trends and context, we want to also highlight some of the clinical evidence base and treatment practices that are foundational to this value-based program. Medications for opioid use disorder, or MOUDs, reduce the risk of death by overdose by 50%, making increasing treatment with an MOUD the clear lever we have to improve outcomes and reduce death. So to that end, if we align with where the field is going, we are making a concerted effort to shift from the term MAT, or medication-assisted treatment, to MOUD. This is considered a less stigmatizing term, and it recognizes that medication is the primary evidence-based treatment versus something that's adjunctive or assisting some other form of treatment. We do hear these terms used pretty much interchangeably in most of the states that we serve, but we just wanted to make that point. The literature also supports that the emergency room is an effective setting to initiate MOUD treatment, and there are many successful best practice examples from multiple states on how to do this. Some examples would be the California Bridge program, but most emergency rooms don't have a process in place to initiate medication for opioid use disorder. We also align with a low threshold buprenorphine approach. This emphasizes eliminating barriers to treatment, and that addresses disparities in access to care. Next slide. So as we designed our program, here are the problems we want to solve. First and foremost, the overdose rate. The rate of members in MOUD treatment, we'd like to see that increase. Access to MOUD treatment, we want to see that increase. Overdose is going to decrease. Disparities in outcomes, including race and geography, should decrease. Retention and treatment should increase. And facility utilization for our members with opioid use disorder, we'd also like to see that decrease, because the best place for care typically is in an outpatient setting for this chronic condition, but we do see it very often in our hospitals and ER. We were able to create a value-based program that touches on these problems, and it's an attractive solution because it incorporates all of these elements. So it's innovative, it aligns with the published evidence base, it drives health equity and quality, it has a medical behavioral integration approach, it's a low lift for a health plan, it has low cost and low financial risk, it incorporates value-based payment and incentives that support a clinician partnership. There's low administrative burden to the clinicians that are participating. And by strategic implementation, we mean that we have states who have intentionally deployed this program in urban areas with high opioid use disorder prevalence, or in hospitals serving high BIPOC patient populations. And we also have states that have decided to deploy this in more rural areas where there's fewer programs that exist. Next slide. So now I'm going to really get into the nuts and bolts of the program. National Medicaid data is showing us that members living with opioid use disorder are often not engaging in primary care or outpatient BH treatment. So a little different than the population we just talked about, or behavioral health treatment. So we're not seeing them in the settings that would probably be most effective. They are rarely admitted to inpatient psychiatric units. However, about half of the members who have opioid use disorder are going to the emergency room at least once, and half of them are going to the emergency room at least twice in a year. So this makes the hospital setting the ideal window of opportunity to engage and start treatment. So we created a value-based payment model and toolkit with the goal of increasing the number of members rapidly started on MOUD treatment in a hospital setting. So there's three primary components to this toolkit. The first are quality incentive payments. So and this is all claims-based, again, to reduce the administrative burden. So there's very little data collection or things that need to happen on the clinician side. If we receive a claim for medication for opioid use disorder within 3 days of discharge, the hospital would receive an incentive payment. But we also want to ensure that we're incentivizing the right care, which is a connection to ongoing care. So there's an additional incentive payment when we see the claim for basically the first refill of the medication. The second component is providing actionable data. So we provided a quarterly dashboard with a number of initiations and follow-up corresponding with payments and missed opportunities. So, if someone came in and that wasn't completed, the facility can track progress on this. It includes also a breakdown of initiation and follow-ups by racial group. And the hospital partners in other states we're working with have been really excited about that data and shared they really aren't getting the insights at that level any other way. The last piece in the toolkit is supportive resources we can provide. Give me just a moment. I'm sorry, I've got a Wi-Fi signal issue. Pardon me, technical, and working it. Just a second. Thank you. I think I'm back on now. Hang on. Okay. So I was talking about providing the actionable data. And then the last piece is supportive resources to help a hospital be successful. It's designed to be really simple. So low burden, which is why we use claims, no additional reporting required by a provider or a facility or the plan. In addition to this dashboard, the incentive to implement universal screening. So basically ask everyone who comes in, don't assume, is another way we think that this will contribute to more equitable treatment rates. So we're not guessing who might need the help. We're just asking everyone if they do. Next slide. And this is our version of basically a patient journeys map, showing our members' experience in the care continuum as they move through and how it would tie to a hospital's incentive payment. We created this to be flexible enough to capture a lot of different scenarios because there's not really a one size fits all here for different hospitals. We know hospitals have different workflows, members have preferences. The bottom line is incentivizing rapid medication for opioid use disorder induction and connection to an outpatient prescriber. So I want to emphasize that we pay the incentive payment regardless of the reason for the visit. In Washington, for example, we see a lot of visits for soft tissue infections, abscesses. It doesn't have to say opioid use disorder on the claim. It's the medication that we're really looking for. So as long as the member has an OUD diagnosis, so you actually do have to put in the diagnosis, I'm sorry, but it doesn't have to be the primary diagnosis for sure. If there's a broken arm, a GI bleed, doesn't have to be an overdose, and we see that diagnosis linked with a medication, that's where universal screening can be really powerful and where the incentive can be gained. Next slide. So of course, for any value-based care program to be successful, there has to be value to the people performing the care. So this program provides incentives, data, resource support to bolster, amplify, and accelerate what's already in place to better serve people with opioid use disorder in the hospital setting. On the right of this slide, you'll see some feedback that we've had from different providers in other states. And they really do see this way to create a sustainable process to bring in some money to partially cover non-reimbursable things that might help this process, like opioid use disorder navigation, social work support. We've also heard from clinical champion providers that being able to attach a dollar amount helps them appeal to broader stakeholders in an organization to augment the argument of, well, it's the right thing to do for patients to treat their chronic medical conditions when they come into the hospital. Think about this a little bit like diabetes. If someone came in kind of off the wagon with their insulin and their diabetes out of control, even if they were there for a respiratory infection, they would be restarted on their insulin and they'd go home with medication and connection to continuing on that. So we want to make sure the same is true for all chronic conditions, including opioid use disorder. Of course, the low administrative burden is really critical. This is generated from claims. You don't have to maintain a list or anything to document or report. And we're also starting to see, it's pretty early days, but we're starting to see in our data as we are live longer that members who are initiated into treatment are actually using facility-based care less and primary care more, which is what we want to see. Next slide. So to close, I'll just anchor on our why. I'm really fortunate to work with a national team that certainly shares our interest and passion in Washington bringing this program to life. It is fairly new. We're scaling it up and excited to be trying it out in Washington fairly soon. But we're here for members. As the opioid epidemic is still raging, there's treatment that can save lives. And this program helps us to deliver our state partners, bringing innovative approaches and addresses a complex public health crisis. This program also aligns with a quintuple aim, and we're able to contribute to the normalization and integration of the treatment of opioid use disorder in the medical setting. Again, thinking about equity, perhaps by medical diagnosis, to having this be on par with other chronic conditions that are routinely treated in hospital and ER settings, as well as enable providers to treat more individuals and address disparities in opioid use disorder outcomes and really meet people where they are showing up and needing the care. So I really want to thank you for the opportunity to share with you today, and happy to take questions.
Thank you so much, Angie. I really appreciate you reviewing that. There's a question that just came in. They just wanted a clarification. Did you mention the size of the MOUD hospital incentive?
No, I did not. That would be something that we wouldn't be able to share in this forum.
Okay, thank you for letting us know. My question was, what infrastructure do you think may need to be in place for hospitals to participate in this opportunity? You were talking a little bit about how it's trying to be low burden and no reporting. I'm just curious if you think there might be some additional steps, such as to support that universal screening or whatnot, to kind of as a starting place for that infrastructure.
Yeah, and Emily, if you don't mind going back, I think it's my 6th slide.
Yeah,
I'll have you just go back a couple, because there's some things I want to touch on that I will forget if I don't. It's not that one, not that one, that one. Thanks so much.
Yeah.
So in the bottom column here, there's this activities to be successful. And really that talks about universal screening, but also comprehensive assessments. Where are people at with this? Is this a new problem for the person, or have they had, on again, off again with their medication and they just need a little bit of encouragement to get back on with it? I did also want to mention, and I forgot to say, that this is multimodal, so it is pretty flexible. We're talking a lot about buprenorphine, but we do have some models that incorporate other different forms of buprenorphine, or even methadone in some cases. Methadone is really tricky because the claims are, I will just say, messy, because there's more federal regulation around it. It's very hard to get that to be a really useful dashboard at this point. That said, we're able to figure out how to work with providers if that's something that they want to do, because MOUD encompasses medications to treat opioid use disorder in the fullness. So thinking about how you would do those, but being able to administer buprenorphine, do you have pharmacy systems in place? How would you discharge with a supply? Where's the person going to get the refill? How do you coordinate discharge appointments and referrals? Do you have somebody on the team that can do that with the person and make sure that that's actually scheduled before they leave the facility, because we know that's going to be successful? Peer recovery specialists a lot of data is coming forward around that. And we're seeing also a lot in the evidence about peer recovery specialists being really important. And then education on harm reduction. So we cannot forget to mention naloxone. We have a naloxone vending machine program here in Washington State that United's been part of in communities, but we want to make sure that folks have that, know how to use it, and that their friends and family do too. So just, again, making sure, just like in my diabetes example, you would have a low blood sugar plan, or in asthma, you'd have an asthma action plan. You would have a safety plan as well around that person going home with medication who has a chronic condition.
Thank you, Angie. Yeah, as I move forward in your slides, just to get to the right place, there was a quick question that came in. Sorry if I missed this. Is this in place with all hospitals in Washington State, or is it just the selected locations right now?
This is in place with no hospitals in Washington State right now. This is a sneak preview from what we've been learning from our early days in other states. So stay tuned.
Thank you so much. And we'll invite our next speaker, Linda Brady, to come forward.
Hi, everybody. Thanks so much. What an engaging conversation. I'm so inspired by the work that's underway to try and address all the I'm going to call them opportunities in front of us to improve this experience with our healthcare systems and delivery system. So could you go on to the next slide? So just a quick word, I'm Linda Brady. I'm part of Boeing's global benefits team. I sit on our healthcare strategy group, and I lead our value-based care initiatives, direct contracting, and also interestingly enough, our healthcare analytics strategy. And it's interesting how the two worlds intertwine so nicely. Because one of the themes I heard from Bindu and from Angie was the way they use data. And I think that's critical if we're going to address equity issues. You have to be able to understand and see your data. So, quick word about Boeing. We are a global organization. We have employees in the US. In every state, I believe we have employees. We cover over 140,000 US lives, which equates to a little over 400,000 lives that we cover. Our annual healthcare spend is $2.5 billion. I will tell you that, with this size population that we work with, and given that we're in every state, we have a very diverse workforce. So working hard to try and come up with solutions that address gaps and disparities in care. Next slide. So, as most companies, we've got the business realities of, what our business is faced with in the community, and, from safety and quality, competition, not just for revenue, but also for talent, the need for efficiency, reducing waste for us and for our members as well. On the previous slide, I mentioned the number of supplier relationships we have. We have relationships with over 20,000 suppliers globally, contracted relationships with over 12,000. And one of our goals in our supply chain management is always to partner with and help our partners make sure that they meet our standards, and we're optimizing these relationships. Our healthcare strategy is designed to support our business realities. We're all familiar here on this call with the triple aim. What are we doing to improve the safety and quality of care and the health outcomes of our people? What are we doing to help eliminate waste? How are we creating affordability? And I think the most important, and the theme you're going to see throughout the rest of my slides, is what are we doing to improve that member experience? On demand, convenient, less time, easy, healthy. From our perspective, where our biggest focus is on access. We think creating access for our members is a pivotal point in terms of addressing disparities in care. Next slide. So in the early 2000s, we launched a program, our intensive outpatient care program, where we partnered with clinics to focus on chronic conditions. So our members with chronic conditions went to a specialized place that was really focused on the protocols for their specific condition and engaging with them on a care management platform. And it was successful and well received. From there, we then morphed into our direct contracting initiatives, where we work directly with health systems in our largest sites. Focusing on Puget Sound was our launch point in 2015. And then in 2018 was our first attempt at a direct contract with a primary care partner. That then morphed in 2022 to a more robust solution, again centered around primary care in Mesa. And now we are engaged in a strategy that's rolling out more primary care solutions in our St. Louis region, as well as in Puget Sound and in locations in Texas. But our focus here is about chasing value, paying for value versus paying for volume, sort of removing the middleman from the conversation so we can talk directly to our partners. It's actually yielded some really interesting clinical innovation that we share across our portfolio of our ACO partners. And then surrounding our primary care solutions with precision referrals. These are referrals to top specialists in the community, but more importantly, with specialists who have availability. So much of our members' frustration and delays in care comes from our members who just simply can't get access. and they're spending hours upon hours to try and find a doctor that's high quality. And by the time they've finished going through their list to find somebody who isn't retired or is accepting new patients or hasn't moved, it is such a frustrating experience that patients either give up altogether, or they just don't care about quality anymore. We're trying to remove those barriers in our strategy. Next slide. So just a quick thing, this is just an overview of our ACO model with our health system partners. And what I want to draw your attention to is it is upside downside risk, but the upside risk is dependent on, certain quality gates that we have in place that are centered around quality metrics. Did the members engaged, is there those with hypertension? Is that controlled? What about diabetes? Are the cancer screenings, gaps in care up to date? Depression monitoring and management, really weren't talking to anybody about this before our ACO relationships. And then, of course, member satisfaction, which includes feedback on access and timing. And up till recently, we've accepted the results of these quality metrics for the entire cohort that's engaged with the health system. We're now starting to transition to attempting to get this data at the cohort specific level. So for example, if we have a partner that's hitting the 75th percentile in terms of best practice when it comes to hypertension monitoring, is that true for all cohorts? Is that true for our, Latino cohort? Is it true for our Black cohort? Is it true for our white cohort? These are the types of things we're trying to drill down because it represents sort of a reality check as well as an opportunity on how we might personalize some of the solutions and services so that we are addressing gaps in care across the board, not just for a select few who may have more resources to actually navigate what is a very complicated delivery system. Next slide. So I'm sure most of you have seen some of these statistics about the need for people to connect to primary care. And I believe, Angie, you mentioned a stat about the number of patients that don't seem to have a routine place or a regular place to go for primary care. We recognize this as a pivotal gap. And so we're trying to close that gap and get more people to trust a usual place for care and start engaging. Our goal is to increase the number of our members that have easy access to primary care and actually take advantage and use that access. And again, from our perspective, this is the theme of our strategy. It's that member experience, making it easy for people to get care. Almost, we want to see it as on demand as is possible. Next slide. So there's a lot, advanced primary care is the current buzzword. I mean, we're hearing it all over the place. And many organizations are coming forward and saying, oh, we absolutely do advanced primary care. And that isn't always true. The intent might be there, but the actual execution isn't quite there yet. So we want this to be, if we're going to have our people and push them back to primary care, we want to make sure it's a solution that delivers for them. It's a solution where when they go to a clinic, if they choose to go in person or even virtually, they have access to all types of services beyond just routine primary care and annual wellness visit. We want them to have access to mental health support that's integrated with their primary care and their conditions. We want them to have access to physical therapy, to the convenience of on-site lab withdrawals, and also well-being activities. If there's a weight management program or a weight issue they want to address, our view is that our point solutions that employers are sort of plugging the holes with actually get embedded into that primary care setting. And of course, the role of prescription drugs. But again, I'm going to repeat myself, sadly. From our perspective, we want people to have easy access, multiple modalities, so that there's a comfort level in all of our cohorts to actually use these services without the unnecessary barrier of being deferred, delayed, ignored, dismissed, or with multiple steps if they're coming to us with chronic conditions that don't make it easy for them to embrace and engage with their care. And the other element I'll mention about the embedded mental health, there needs to be a connection to community resources that address what we call the non-health challenges or barriers to getting health care. And we work closely with our first primary care partner in this space, recognizing that there are a number of things that contribute to poor outcomes. It could be that they can't get to the appointment because there's no transportation support. It could be that there are asthma issues and getting them into the ER is due to the fact that they're renting an apartment that used to have pets. And so how can we help them do a clean of that apartment so we can minimize the amount of time or the episodes that they're experiencing with their asthma. So that is sort of another key component of the solutions we're trying to put in place, where our providers who are actually delivering the care can assess what type of additional support our members may need to improve their outcomes and their engagement with their care. Next slide. So I'm going to take the last few minutes to talk about and go back to the themes Angie and Bindu also touched on, which is data. You measure what matters. If we're not able to look at our data and understand what's happening in our cohorts, then we're never going to get to the right answers and how we address these gaps in care. We've talked to our suppliers about asking them to start reporting their results based on outcomes. We've figured out when we first started on this path, we discovered that our insurance carrier had no idea how to break the data up by cohort. The best they could do is break the data up by zip code, which all of us know is not enough. It's not insufficient, but it's certainly not enough to understand the challenges that may face particular groups within our workforce. And so we have an annual health risk assessment that we ask our employees to participate in. And it's got a significantly high rate of response rate among our employees and their spouses, their covered spouses. And in that health risk assessment, we do ask questions about ethnicity, race, sexual preferences, gender identity. We actually found a way that data is pushed into our data warehouse. By using that data, we are actually able to start looking at patterns, utilization patterns, condition patterns, the relationship between conditions and care and spend. And when we started doing this exercise and exploring, we shouldn't have been surprised, but we discovered and confirmed that our data was consistent with what we were hearing nationally in terms of gaps in care. And it's actually provoked us to take some near-term steps in terms of benefits that we offer, but actually stepping back and thinking how we might communicate differently with our cohorts to help them better utilize the benefits and most importantly, the primary care services that we're bringing forward. Next slide.
Linda, I'll move to the next slide. I'm just going to let you know we'll need to kind of wrap up in a little bit.
Yep, I'll wrap it up right
section.
now.
Thank you.
Just this, I already talked about this slide. This is just where we started. We figured out the profiles and we started looking at health status, conditions, what level of prevention the cohorts were engaged in, and how they utilized care. And then the next slide, which I think is my final slide, is really looking at the conditions and drilling down. So we've got a high level view. And then when we started drilling down, we started discovering more issues, more I think specific concerns about driving outcomes. So I'll stop talking. Thanks so much for your time.
Thank you so much, Linda. We have just a couple questions. I can see there's this part two is some of your ongoing work. I'll leave that up so people can see it. There was just a question in your presentation. You referred to the term quality gate. There's a question on, can you give an example of what a quality gate is?
So we have upside and downside risk in our arrangements with our with our health systems. If we generate savings from the arrangement and they're responsible for total cost of care, then our partners get a percentage of that savings. And but they only get a percentage of that savings if they meet certain quality metrics. So it's not automatic. They have to meet certain quality targets that we set, and we set them in partnership with them, and also based on actual results.
Thanks. And I just have one more question for you. On your previous slide, you can see that you've highlighted 3 topic areas that you're focusing on. I'm just curious kind of how you went about making this decision and identifying these 3 areas.
Well, it's interesting because, there are so many opportunities. Diabetes is obviously a prevalence among our population, not just diabetes, but pre-diabetes. We also were noticing significant trends in select markets around the use of the emergency room, which often tells us there's some type of access issue, depending on the average allowed amount. So we wanted to dig down to understand why people were going. And we found a really incredible theme among one of our cohorts, specifically using the AR for a specific concern. And their spend was pretty high when it came to other benefits that they were using. So it just gave us more insight. And that was just our starting point. So we looked at what was prevalent, what was, high utilization, and what was high cost
Perfect. Thank
or
you so
bad
much.
outcomes.
Yeah, that makes a lot of sense. We will transition now to the large group discussion. So I'll invite the other speakers to come off of mute and on camera if they are able to as well. And if anybody has questions for our panelists, please place your questions again in that Q&A box. I'm going to stop sharing so we can see everybody's lovely faces. There was kind of a question that came in and about the role of patients. And so it made me reflect a little bit on how in the start of this webinar, we stated that value-based payment is a payment method for clinicians that rewards them for the quality of healthcare they provide, rather than the volume or number of patients they see. But how do we know it is quality without input from a patient? So the question that we have is, how can we better build a system of accountability by carving out a bigger role for our consumers and patients?
I think one way would be patient survey, especially differentiating them by race and ethnicity also, because patient experience can be very variable, and to compare patient experience by different groups and see if some of the disparities may be related to poor patient experience as well.
Thank you.
Bindu, I would add to that utilization. Like you use what you like, what works for you, what resonates. And one of the things that we've talked to our partners, especially in the primary care space, is if people come back and people are engaged, then they're doing their job. They're doing something right. If people aren't doing that, that's a signal to us that something's off. Something about that experience isn't working or isn't resonating.
And I'll just add, I think this is a really important point, and thanks to whoever asked the question. Many of our value-based programs in government programs in particular do incorporate a patient satisfaction factor. And I think about the CAPS survey, for example, as a piece of this. So STARS programs for Medicare come to mind, where the voice of the patient is included in that assessment of how well we're doing in things. So, but certainly member forums are something that we think about as far as how do we do that. I know that some of the groups we work with also have patient advisory councils that can be helpful in determining value and that as well.
Another question that just came in was that they are really grateful for these examples that you've each provided today. And overall, it seems that community involvement looks to be very key in these processes. What are some ideas to begin this engagement with the respective community as a whole? I might direct that at Dr. Nayak first, because I know you've been doing quite a bit with trying to get involved with your community in different spaces.
Yeah, I mean, I think the involvement with community-based organizations is one way to reach a marginalized community, and to make those relationships, make those relationships within your community with community-based organizations. It is a trust building process and takes time, but it's so important. But gaining perspective from the community that is at risk is critical to understand their perspective on the disease process, on their patient experience, and on what is needed or what they need.
I'll jump in and just add that it's, also forums like these that help engage with the community. It brings like-minded leaders in different organizations from different groups, from the health systems, health insurance companies, employers, foundations, associations. I think it's a problem we all share. And I think just sort of combining our forces, our best thinking, and as an employer, as a purchaser, trying to facilitate. We with our partners, they probably think that we think we can deliver care because we're so opinionated about it. But I think what we can do is help facilitate the connection with our provider partners and community resources.
And I also think about the BRIE as a really good example of what you were just talking about, Linda, where we do have all the P's coming together, including patients, on our recommendation groups, on our work groups. And then certainly public meetings are extremely important as well. And that's something that the BRIE really excels at too. So delighted to be a part of those forums, and thanking you as well as for bringing everybody together in this way.
Angie? My next question is kind of like, what actions, so value-based payment and value-based care and kind of health equity, they are these important topics, hot topics, but it's been kind of slowly going, and sometimes it can be hard to get everyone on board to be behind these and really feeling dedicated to this work and moving it forward. We were just curious, what actions have you or your organization taken to kind of get everyone on board within your organization to help adopt value-based care or adopt these health equity work that you've been leading?
Well, health equity dashboards is one thing that we're doing at Confluence Health, and we're publishing the health metrics by race and ethnicity for certain metrics like diabetes control, hypertension, colon cancer screening, breast cancer screening. And if you can display data to people, then they believe that there is a disparity present, because you can show that that's the case. So that, I think that's probably one of the most important ways that we can emphasize health equity, is to document health disparities.
And Dr. Naik, in that vein, also documenting like the possibility of improvement. So when I thought about your COVID vaccination program and the fact that you were able to see the disparity before and after, and how there'd been a change in the percentage, that really does encourage people to come to the table thinking about not just, oh, there's this insurmountable problem, but there are best practices, known solutions, and here's data that suggests that change is really possible. I think there's also a listening component to stakeholders in the organization. There are a lot of things in healthcare that are the right and best thing to do, and there's a little bit of a tyranny of the urgent all the time. So just as if you were working with any community, you would want to listen first to what the barriers, challenges, competing priorities were, and then really tailor how you're talking about health equity, and really centering it in any of those processes that might actually help them turn from a barrier to a solution. But there is a back and forth listening piece too.
Absolutely. I think, Angela, what you said about people don't think that these barriers that you can overcome these. I think that is a common thought that people have, and maybe they don't realize they have that thought, that these disparities are insurmountable. And when in fact we know that there are actions that can be taken to change outcomes and improve outcomes for marginalized communities.
I think just be really willing to share too. So I've certainly build on what the two of you just said. But the need to, for those of us who have been doing it and doing it successfully, sharing those results, because I think that's very powerful, like the improvement. I think sharing the things that didn't work, I think is equally important. And sharing how we did it, telling that story so that others might not think it's so daunting. We do hear a lot from other employers, well, we're not Boeing. And it always makes me step back a little bit. It's like, you don't have to be Boeing to start these initiatives, to do this work. We have a healthcare system that's actually gotten quite adept at value-based payment plans. And so there is a pathway, but it does require being willing to share, those of us who are doing it at the forefront, and organize and work together.
Linda, I wanted to mention too, I saw on one of your slides the advice to start small, and to really, I think focus is another key theme in doing health equity work, because the reason it sometimes seems insurmountable is that if you're looking for disparities, you're going to find them across the board in your quality data. And so where to start and where to look. So being able to focus first by meeting in community with the affected patients, listening to what the barriers are, what are the top priorities, and then really prioritizing and doing analysis and evaluation well, so that those first steps that any organization is taking to start using race, ethnicity, stratified data, for example, looking at a particular single metric or that sort of thing, can also really help dip a toe in and then build upon that success over time. And then just a shout out that we need more research on best practices in improving health disparities. We have a ton of research on identifying them, and the more that there can be published on how do you close those gaps in different communities, the smarter we will all get, and the easier, hopefully, that this work will get.
Yeah, here. I think that's an excellent point. You may, once you find out that you've got them, what do you do? What are the best practices and what's within your control to do? And having examples or people have tried something in a platform where we can share it easily across the board. Really, excellent point.
And I know we have, at least in this state, some of our smartest academic minds on the case. It takes a while to get that stuff published. So keep on it. We're anxiously waiting and listening as it's coming out.
I think that, yeah, there isn't much out there as far as evidence-based work on how to improve health disparities. So it's kind of a work in progress. And I think a lot of medical centers are going forward with their health disparity action plans and seeing how they work out, because that's all that we can do right now, since there is not that evidence-based on what is the best way to do it.
Well, I think that's an excellent spot to kind of leave us off as we go into closing, where that kind of leads us where, just as again, a reminder, this webinar is recorded and we will post online for everyone to access. There was a post survey that was added into the chat that we're hoping you can provide us some feedback on your experience joining us today. But something that was just touched upon was, how do we know things are going on in the state, and what is going on, and what are the lessons learned? We are actually having a webinar in April. We're referring to a learning lab where we have Dr. Leo Morales joining us and talking about the work that he and the University of Washington and the I think it's Center for Latino Health have been leading with connecting with Latino communities on diabetes care within the King County area. So he is going to share how he has been working with Adios COVID to support the different Latino X communities within King County, to support them and connect them to care. And we'll have the opportunity to learn from him on Wednesday, April 24th from 12 to 1:15 p.m. If you would like to join us, there's also opportunity to connect with peers and to attain CME from that webinar. You also heard in the webinar today the impact and the importance of data. That is going to be the focus for our next webinar as part of this Catalyst for Change series, is really focusing in on that data and health equity piece within the value-based care space. And you also kindly heard Dr. Nyack talk about the Health Equity Action Collaborative that is hosted by the BRE Collaborative, which is a program underneath the foundation. And the Health Equity Action Collaborative, we are doing another cohort of this in 2024. So if you would like to join us, please let us know. We will send out information for this opportunity in the email after this event. And I think the link is also posted in the chat, but we would encourage those who are interested in receiving some quality improvement support and centering health equity within your quality improvement designs to come join us and connect with peers. And that group we hope to start in May. But thank you everybody for joining us today. And thank you so much to our speakers for providing us with your time and knowledge and expertise. We really, really appreciate it, but we will end there. And thank you, everyone.
Thank you.
Thank you all.